start, and please wave when I say your names so that people can see your beautiful faces, with Kendra Kapanis, the Executive Director of Generate Health. Ms. Kapanis has overseen health-related nonprofit organizations focused on improving the health of vulnerable women and children for more than 25 years. She serves as the Executive Director of Generate Health. Kendra has led the organization through many changes, including its most important mission change and commitment to eliminate racial disparities in maternal and infant health. Much of her work is focused on creating greater health equity and access for women and children, supporting maternal health services for expectant and new mothers. She's been instrumental in leading Flourish St. Louis, a community-wide initiative made up of many sectors tackling these complex systemic issues. Thank you so much for being here today, Kendra. Next, I'd like to introduce you to Queen Okunshula Amadou, the founder and CEO of Jamba Birth Village. She is a 17-time award-winning Black maternal health pioneer, recognized in Missouri as the first Black certified professional midwife and the first Black registered preceptor through the North American Registry of Midwives. Can we just show some love for that? Get your tissues out, and is currently training her firstborn son as a Black male midwife. On Juneteenth of 2020, Ms. Amadou opened Missouri's first Black-led midwifery clinic. In 2022, she led an initiative to purchase 1 acre of land in Ferguson, just 1 block from their midwifery clinic, to build an innovative and pioneering Black-led birth center and postpartum retreat haven. I am so thankful for her leadership. Thank you for being here today. Last and certainly not least, I'd like to introduce you to the chair of the Department of Obstetrics and Gynecology, Dr. Dineo Kabele of Washington University School of Medicine, a graduate of Columbia University. She's a state and national leader in OBGYN. I remember where I was. I'm not even making this up. I remember where I was, where we got the email at WashU. You see, I was a fellow, and I was a fellow who did not see Black leadership. I did not see role models for who I could be in this space. She was the first Black department chair, Black woman department chair ever announced, and it resonated through the halls. We called each other, we sent each other texts. It was huge. And I want to say something that she said to me. She checked me last year around this time. We were at a meeting and I was talking about all of the, Black women are 3 times more likely to die. Black women are gonna die. That's what we do in Black Maternal Fetal Health Week. That's what it feels like every year. Is it not anxiety provoking? Every year, right? And she gently but firmly said, let's change the narrative, sis. With your platform, let's talk about the joy there within. And she may not know this, but that meant a lot to me. So thank you for being a mentor and sponsor, for saying the truth and not just padding it, and for checking me, because it has changed how I show up in spaces, very seriously. It's changed how I show up in community. So Dr. Dineo Kabele. So we'd like to make this conversational. I'm not going to call on folks. I think you all are professional enough and have done this enough to not, beat each other to the mic or have any fights about who goes first. So we've got a few prepared questions, and then we have mics that we will bring around the room, because this should be a networking opportunity itself. I challenge you to look around, and if there's people you haven't collaborated with, that's how we're going to end today. We're going to end early so that you can network and collaborate, and so we can take some selfies because we cute. So the first question is, in an ideal world, what does equitable maternal child health look like? Who wants to bring us out on the panel? In an ideal world, what does equitable maternal child health look like? I knew it was you. I knew.
I did pause.
Oh, you did. I saw you do it. You paused, you waited, you looked, and you said, okay, let's go.
Absolutely. First, I just want to thank you so much, Dr. Mahdi, for all the work that you do and for uplifting all of us across the region to collaboratively work together. And also thank you to the Missouri Foundation for Health for hosting us. And I want to start by saying that in order for us to envision equitable maternal health, it's for midwives to be integrated at every single level of healthcare. That means that there's access to midwives in the hospital, there's access to midwives in birth centers, and there's access to midwives in home birth settings. Why? Because 90% of pregnant people start their pregnancies off with being low risk. And so if we think about midwives, they're low-risk providers and they specialize in low-risk care, helping to keep pregnant people low-risk and healthy, and they know how to risk their patients out of care if they no longer fit within their risk range. So there's enough room for midwives to collaborate with obstetricians and midwives to collaborate with neonatologists and maternal fetal medicine doctors so that we can all take care of moms and make sure that they have what they need. And I just look at care providers and care systems across the world. In the United States, where we have the worst outcomes, we are one of the only countries in the developed nations that have not integrated midwives into the care system.
That's right.
And our rates get worse every year. In these countries, while they do still have maternal mortality issues, their rates are not steadily increasing and getting worse every year. So we really need to look at that to reach risk appropriate care here in the United States of America and in the state of Missouri.
Thank you. I love that. And starting off the panel right, because even as a physician, it irks me how we center physicians in the care of human beings. It's truly a team-based approach. I tell the story to my mentors and medical students. Oftentimes, I only get 15, 20 minutes with the patient, but do you know who's with them all the time? Our social workers. You know who's with them all the time and knows their families by name? Our CHWs, right? Our midwives, right? And the incredible team-centered way that we should be looking at it. So I love that you opened up that question. How else do the panel see, in an ideal world, what equitable maternal child health should look like?
So I'll just jump in, and I'm a physician. I actually owned a birth center also. And so in the state of Texas, a physician owned birth center, I employed midwives. So it's important to me. So for me, the, for women to have choice is important. So, and I want to protect that choice in the best way that I knew how, because I had a huge client. My New York friends called me granola, right? They call me granola because, but I did a lot of natural childbirth. I had a huge clientele that preferred unmedicated birth. I did a lot of vaginal birth after cesarean. So when you think about an equitable environment for maternal care, quality has to be infused, comprehensive services, and then I always had practice in a collaborative care model. And that's important because you will have women that make particular decisions, right? But you said something that was key, and I wish that that was talked about more, that for me it's about women accessing also the right care provider, and care providers understanding, respecting what that's like, because she said it best, everyone's not a candidate for a low risk birth, right? And with the low risk birth, you can have a midwife, but there are some people that are just not candidates. There are people who are not candidates for out of hospital birth or birth center birth, and so that's that risk stratification that is so important. But that's again informing women around that, because we all want to work collaboratively and collectively together to get people in the best setting for their health.
I'd like to follow up with that because, as the chair of obstetrics and gynecology at Washington University and also the chief of obstetrics and gynecology at Barnes-Jewish Hospital, I consider our role as, we provide the continuity of care from low risk to high risk. But if you have a high risk pregnancy and if you are in trouble in other places, I consider us the wall. I consider us the place to come where if you have the most complex, most difficult situation, we will take care of you. And I don't think we have a problem doing that. What we're working on now is showing how we care. So we will certainly save your life. Um, we also want to do it with the highest level of compassion so that when you walk out of our hospital, you don't just thank us for saving your life. You had that experience that made you feel worthy and made you feel taken care of. And so that's that joy piece that we need to put into this. Wherever you're seeking your care or wherever you're receiving your care, whatever risk stratification we have in place, it's very, very important that you feel like you received care that, as the mayor said, that you deserve.
Yeah, I think that deserves applause. At Generate Health, our vision is that all Black women will have an experience that they never question, did they get worse care or feel disrespected or wonder if the quality was not as good because of their race. That should never be the case. That all Black women should experience care in a way that meets their needs. They have the choice, the access to the robust team and services that they deserve and desire. And so I think for us, the vision of the future of equitable maternal child health is where there is no question that you're going to get the care that feels respectful and that you feel cared for and loved.
That's right. I love that. It's a beautiful and hopeful way to start. But let's call out the truth, right? Because we know for all these beautiful things that are said, and I look out around across this room, you all have been doing this way before I was even conceived of for this role. You are the folks that people trust. You see this work every day, so we know that there are challenges. So my next question to the panel is: what are the biggest challenges that you feel parents to be are facing in St. Louis? If we could call out a few of those, and then when we get to open discussion, we can talk about some of the solutions and the incredible things that you all are doing in that space to address them. What are some of the biggest challenges we have in St. Louis?
Where do we start?
I was about to say.
No, so I think one of the things that we're working on through the health system and through Washington University is actually going into communities, not waiting for people to come to us. So this is the second year in a row we are hosting Black Maternal Health Week, where we'll have a series of events all week in the second week in April. But we are also this weekend going to be at Christian Hospital, partnering with the community partnership with the Links Incorporated, where we
The
will
Links
have.
are here today. If the wonderful women
Yes,
leaders
yes,
of the
yes,
Links
yes.
could just wave so the room can see
Yes.
an honor.
So it's a Black Family Expo, and I think what you were talking about health literacy, we're going to have materials. We will also have some of our providers show up who don't necessarily look like the people that they're serving, but are going to show up at Christian Hospital in the community to start talking about what early prenatal care looks like, what breastfeeding looks like, providing materials. And I think that more of those events that we can do in partnership with multiple people. The second thing that I would say is we have very powerful federally qualified health clinics here in St. Louis. And we have our health department in St. Louis City and County. How do we coordinate efforts? How do we coordinate efforts? Because we have the people who are doing the work in the city and in the county. We must be better coordinated, and this is part of that effort. So
I love that you said that, Dr. Cabell. One of the things that keeps me up at night, right, is I know all these incredible leaders, but we just lack the capacity, it feels like sometimes. The work is so heavy that it's hard to reach out. I know that I was like buried under a wave of just stabilizing my department coming out of COVID. So we're so tired of hearing about silos, silos, silos. We get it. It's just such an overplayed buzzword, but it's still real. So I just love that you called out greater collaboration. Even if it's hard, we just have to do better. And it's how that coordination looks like. And somebody said to me, what's hard is who is the convener? There's so many leaders, and each space thinks of itself as the convener. Is one of the issues? I'd love to hear more about that because all of the conveners are here today. I'm looking at you, Anduele. I'm looking at you, Kanika. All the conveners are here. So let's see if we feel like we play together well in the Sandlot. Let's discuss that a little bit later. But what are other challenges that Anduele, you didn't think I was not going to call you out today, bruh? You almost thought you got away with it. But other challenges that you think we face in St. Louis, Kendra or Okunshula?
Yes, one of the biggest challenges that we face is families not feeling empowered. So they feel powerless, they don't truly know their options. And so we deal with a lack of informed choice. We deal a lot with informed consent where parents are told what to do or pregnant women are told what to do, but they're not giving a full range of choices in order to make those best decisions. Oftentimes, mothers also feel like if they speak up, for themselves, that, they may be looked at as disruptive, or, they may kind of face some adverse outcomes if they're in the labor and the delivery role. So one of the things that we think is really important to bring awareness to is doulas, and that was already brought up earlier. But doulas are at the community level. They help to build a relationship with the pregnant person throughout the entire, pregnancy process, even sometimes preconception as well. So you have a strong continuity of care, versus when someone is delivering in the hospital space. Typically, this is a brand new team that you may be meeting for the first time. Sometimes you may be delivering with the house doctor if your provider isn't available. And so doulas really help people to know their full range of choices. They make sure that their voices are heard. They do help to disrupt harm in the birthing spaces. And so I think that that is something that's really important, and that's something that's also missing.
Love that. Love that.
I would just want to add that I think the challenges that parents to be are facing go beyond just the pregnancy and the care that they may need for that for their health, but they're coming into this in our community lacking access to safe and affordable housing and job opportunities and childcare and all of the things that go around families. And I think the focus is so much on the care, the health care, and less on meeting some of the immediate needs for moms. I think that the doula, kind of partnering with doulas, but also with the community health worker mindset orientation that can, I believe every new pregnant person needs to have a buddy, a person, a community health worker, doula who is by their side throughout. This is one of the most transformative, major life changes that a human can go through, and we leave them, we leave our women on their own to navigate and to find. Where we as organizations and providers can't even navigate all of the resources in our community, how do we expect individuals facing such tremendous change in their life to do that? And also in spite of, and navigating so many different systems. It's not just healthcare, it's every system that they're encountering in their life. So I think we need to have more really high touch community health workers paired up with pregnant women. And I think the combination of doula, community health worker is a powerful combination.
Yes. Do we have any other doulas in the space today, or people training to be doulas? Can you stand and take a bow, please? Yeah, we honor you. We honor you. I want you to see them and make sure you connect with them before you leave. Do we have any CHWs or people training to be CHWs today? Yep, my baby in the back. Please stand as well. We'd like you to take a bow. Stand. Yeah. These are such important parts of our team. They've taught me and they've stretched me and they've grown me as well. So I just love that you hear this panel saying over and over and over and over and over and over and over again, integrated care, right? And not just centering. This is the stories of Black women. We are not monolithic, baby. And I love when the press likes me to be the role model and to speak on behalf of Black women. Some Black women don't even like me, child. I can't do that. You know what I'm saying? We are so beautifully diverse within our Blackness, right? And so to think that the care would be monolithic and vanilla and one-sided is ridiculous. So I honor my doulas, I honor my nurses, I honor my social workers, I honor my CHWs, I honor my midwives today, because once we learn that having all of us in the conversation is integral to the success of this, we will never move these metrics. And to me, and what I'm hearing from this panel again today is no matter what question I ask, it comes back to that, right? So let's let that sink in. And I want people in the crowd to be thinking about, all of you say these same things too. I've heard a lot of you talk. So what's the missing piece? What's the part in the open discussion that you want us to maybe figure out in this room? Because we can do that. This wasn't just free lunch today. I think we can fix something today. I really do. I believe that. I'm stubborn that way. Ask my husband, who's here, by the way. Hey, Dr. Jesse Davis. He thought Today would be the day I would keep it together. He thought, baby, no. So I'm gonna fast forward to the last question because as much as I love panels and people being at mics, I really want to hear from some of you today. And we're just gonna open it up and just talk like we're at home. So I'm gonna go to the question on the screen of what is St. Louis doing well, right? What is St. Louis doing well to support mothers and children? So that, and I'll ask Dr. Lawson to come in at the tail end of that to see what she thinks about that from her wide national scope, right? But let's talk about what we're doing well, right? So who wants to lead that off? What are we doing well in this space?
I would say that we're growing.
Yes.
We are growing in the maternal child health sector. We are growing both community-based providers, but we're also growing in Black nurses and Black OBs. And we just grew 2 more new Black nurse midwives right in North Carolina, right in Ferguson. I am so excited. And we need more across the region. And so I feel like us being able to grow at both a community provider level and at the hospital level, that's really, really helping to integrate us. And while we don't have the solutions that we need right now, I'm very, very hopeful because of that. And another thing is that we're sharing our visions so much more together.
Are we not?
We are.
I think we are,
We
y'all.
really
Anyway.
are. So as we grow, we're like, hey, what can you do? And we're just sharing resources, we're sharing visions, and we're starting to match together the people who work well together. And I feel like we're coming more together as a region to just bring awareness to families on how to reach those providers. So that brings me a little bit of hope.
Yes, thank you. What else are we doing well? And not to put you on the spot, Dr. Cabelli, but what people also need to just Google her tonight. Please do. So great. But can you talk a little bit about your research? Because I do believe that research is so important in moving forward the conversation. What I've loved about your career and the way that you have grown your department is how integrated your research is, and the implementation strategies you all are doing are truly visionary at a global and national level too. So you can say whatever you wanted to say about what St. Louis is doing well, but I'd love to plant a little bit about the research that you're leading as well.
Well, I'm going to flip the answer a little bit because I want to talk about what attracted me to St. Louis. You said, what is St. Louis doing well? What a couple of things that attracted me to this position. One is Washington University in St. Louis and the chancellor's call for Washington University in St. Louis to not just be parked here, but for St. Louis. And then we're adding on pieces with St. Louis. And if a city like St. Louis can do this kind of work in partnership with this powerhouse academic medical center and this powerhouse health system in the BJC health system, we could be the model for the rest of the country. So since I've been here, I started in June of 2020, we've been able to recruit, I just signed my 30th new recruit.
Come on, y'all.
To St. Louis, Missouri, obstetrics and gynecology. So when you think about the state of Missouri that has 30 counties that are OBGYN deserts, when you think about the fact that we now have presence across the city and the region with the work that we're doing, that's what St. Louis has to offer. And people ask me, well, how are you recruiting people here? And I say every challenge to me is an opportunity. And if you see this as an opportunity to model how to do this kind of work from the middle of the country with the kind of city that St. Louis is, you can make an impact nationally. And so I'm not going to talk specifically about my research per se, but just the teams that we're able to build and show and model how we can do this work from the middle of the country. That's why I'm in St. Louis.
I love that. I love that. And I want to get a bit real raw and honest as well, right? She also came at a time where she was the first. And it's ridiculous in 2024 that I've had to introduce so many the firsts. And that speaks to the systems of oppression and white supremacy that we still deal with every single day, okay? Every single day. But anytime someone tries to take the conversation there, she doesn't ignore it. Notice that. I want you to notice the way she speaks, right? She acknowledges, she knows very well what she stepped into. None of you in this room can even imagine what it's like for her to continue to be the first, right? but she has grown. She's attracting talent. She said, we will role model through that. And to me, that is leadership. That is aspirational. So yes, Washington University, St. Louis University have a lot to contend with. The history of racism that came out of these academic institutions here, right? We all know what happened, right? Is still prevalent today. But her mere presence, her mere leadership, and the way that she models is changing that communication, that conversation. And so I really appreciate the way that you show up. I appreciate how since you've been here, I've seen a lot more acknowledgement. There's some really historic and beautiful work that's coming out at WashU. They're putting up and archiving the history of racism in medicine at WashU. It's an incredible thing that they're putting together. And it's that kind of acknowledgement, but more importantly, not staying there. We can't always stay there, right? And she does that every day. So thank you for honoring your team, but for talking about how we role model. She hates being honored. I just don't know how do you think you can have this position and be you and it doesn't happen, Dr. I can't. Kendra, what else are we doing right in St. Louis?
Well, I think we have a pretty good list of things that we're doing right. We have, I think, it's no better time or better opportunity in this community to make some real progress. We have leadership that's been spoken about and prevalent and displayed here today that's amazing, and leading in a way from love and about opportunity and possibility, and not just about the disparities and the mortality, but what is it that's going to get us to a community of vitality. And that shift is really important, that we are moving in that direction. So I think leadership, we have buy-in from institutions in ways that we haven't seen before. We have a robust workforce of Black doulas, community health workers, midwives growing, as Ogunsola said. We have statewide initiatives to focus on clinical quality improvement. So there's some state leadership and work and investment. And I think that this community is moving forward despite some of the climate at the state that could be chilling and dampening of efforts to focus on equity, but our community is moving ahead. The maternal child health community is pursuing, and there's critical mass to keep this ball rolling. So I think this is a really opportune time with a lot of things in place to make progress.
That's awesome. Dr. Lawson, what does that make you think? And how do you respond to some of these?
So, empathetic leadership. It's obvious to me there's empathetic leadership here. It's obvious to me for a lot of reasons, just this room, right? The different and various types of stakeholders that are here. That's important. One of the things I think you started out talking about was the narrative. And that's probably one of the things as I'm on my road show, I talk about this a lot. There's this narrative around Black maternal health, right? And so it's become this narrative that now I have young women walking into my office, I'm never going to have a baby. I have young men at 20 years old going to get vasectomies, right? So it's a narrative, and I think you mentioned it earlier, and I trust that the leadership here is doing that, is working on that narrative, right? This isn't a new problem or a new situation. Let's just be clear. Black women have had disproportionate and disparities for over 100 years, ever since it's been tracked. It's not new. And so I was in the elevator there a few weeks ago, and a young woman said to me, I just didn't know we died. I didn't know, and people say it's worsening. But again, there's context, right? And so a lot of the historical interventions and the historical context is missing. And it's so important to have these types of leaders that you have here in this city, in this state, in institutions, representing, putting things in context for our communities, right? Because there's a vernacular that can be used. And so you're doing many things right. Your demonstration of just you being here, standing up in your positions is part of that. Right? And I'm just happy to be here and be a part of it and sharing the conversation. Really am.
Oh, we so joyful.
Yes.
All right, I'm gonna wrap up the questions. Y'all have been so nice. Let me tell you, I'm looking out across the crowd. You ain't on your phones. Y'all look interested, even if you're not. I'm proud of us, folks. We did it. We did it, Joe. We did it. Um, but we gonna open it up to the crowd. And as my friends know, I voluntold people too. So let me warn the people I'm gonna voluntold while I also let some of you volunteer. We coming to you first, baby girl. So I need you to, if you chewing, I need you to chew. I'm very excited. Today is another historic day. We elected a new board chair for the Department of Health for the city of St. Louis. That is the April Jolly, who's standing right here. Please stand and take a bow. So, as much as you may have thought we're going to ease you in, one of your first roles is I'm going to come to you to volunteer you today. We also have a celebrity in our mix, y'all. Get your, if you want an autograph, one of the participants of the video you saw earlier is sitting right here. The homie, but also an incredible leader who has spanned many industries and is now an innovative force around this conversation. So Ronke Faletti is here with us today, and I'm going to volunteer you too. So get ready. So the people with the mics, these 3 tables, as soon as it dries up, I do need us here. And the table in the back, my leadership, the Department of Health is here today. Can every single leader in the Department of Health and person who works with me, alongside me, and fights with me, please stand. So my people, you can see my people. This is my family. Suzanne, warm up your larynx, girl. I want you to touch a little bit on congenital syphilis and the crisis and the incredible leadership that the county has helped us to convene around the Congenital Review Syphilis Board as well, because this is one of the biggest crises facing birthing mothers. So now it's open. Let's talk. You guys have done a lot of active listening. What did you agree with? What did you not? Do you want to shout out your business? Do you want to say that you disagree? We're going to let, Lakeisha, girl, you know I'm consistent, girl. It's always gonna be like this. Do you love it? Okay. Okay.
We have a question over to Dr.
She can't stop laughing. So we do have a question or a
Yep.
comment.
Yes.
So please introduce yourself and let's get this started.
No problem. Thank you all so much for your amazing panel. It's always good to be in the company of revolutionary people who are actually showing up and doing the work every single day. I am Najwa Walden. I'm a PhD student at WashU in Public Health Sciences, and I also have a startup by the name of Balancetopia, which focuses on providing nutrition education to help people prevent and reverse diet-related conditions during the perinatal period. And a lot of times I show up to these types of conversations on maternal and child health, and they're very pregnancy focused. And after the child is delivered, then we talk about the infant outcomes, but we also understand that motherhood and the process of preparing for pregnancy happens well before conception, and the health of the mother continues on well for years and years because postpartum is forever. And so the question that I have for the panelists is, are there any additional resources, whether it be programs or services, that need to be developed or need to be scaled in the region so that when we think about the life course of motherhood, we're able to enable health before conception and after childbirth?
Gosh, can we just give her a round of applause? I'm so sorry. Whew. I see Risa, girl, Risa. I need you to walk over there. Okay, I'm gonna tell you about this sister real soon because we know each other through so many communications, but I'm welling up because it's beautiful to see you show up. Thank you for taking the time. PhD leader extraordinaire. That was so beautifully put. So, I'm going to put myself on the spot first because this is a challenge. When I joined the health department, we had less than 10 people doing the work of maternal child health for the whole city. So we're going to start there. The fact that we continue to think we can under prioritize public health coming out of a historic pandemic, where public health is literally the implementation arm. It frustrated me that physicians were always centered as the front line, even though I was a physician on the front line every day in the hospital after just having a baby. So I know I went to work on behalf of my people. But it frustrates me that we continue to talk about this in that monolithic view. So, and it frustrates me that public health is so under-resourced. So the first thing is that at a national level, what Dr. Lawson is doing is advocating for the prioritization of public health. That's number one. We lost 121,000 public health workers by the end of 2021. And it's projected that by the end of next year, that number will be 250,000. I'll tell you that I did my research, because as much as I talk a lot, they call me Mati Fadza, keep a receipt, Clutchwire Davis, for a reason. And we had 2 epidemiologists for the whole city of St. Louis. We now have 11 because my good friend, Dr. Corey Bradley, says data is justice. So we use data to really talk about what's the landscape of what's happening right now. And one of those things is, you heard me say 50th out of 50 in per capita spending on public health. In this state, we think only $7 per capita is what we are all worth in this room and in our communities. It's astounding. I had less than 1% of the city's budget, and with the support of the mayor and my boss, Nancy Cross, who's here today, Chief Operating Officer for the city of St. Louis, so let's give her a round of applause. We've got the budget up to just over 2%, and they fight on my behalf every day, but it's still a challenge, because when you guys answer their polls and their surveys, you don't say you care about health or public health. That's the truth, if we're going to call it a buck, right? So I really think that that's one of the first things, is we can't have that conversation until we talk about bringing the prioritization of public health back to the fore. There's a lot of research that says a thriving economy depends on a thriving health of a society. That's facts, right? But to get to the core of your question, one of the things that I did with Bobby Williams, who is the bureau chief for our family community school health, where maternal child health is vested, is exactly that. I said, Bobby, we don't even know if we are really honoring this work. So we took the same model for the cascade of care that HIV has done. And HIV has modeled this, right? And we laid it out, and then we built it for women. And I said to him, you can't, and he came back with it. And where did we start? With pregnant women. Jillian's nodding her head because she helped him build it, right? We started with pregnant women, and we had to challenge ourselves to say it starts way before. Then we superimposed our programs on top of that cascade of care in order to see where the gaps are. So I challenge all of you today to do a similar exercise. Build out your own cascade of care across the spectrum of birthing. Then superimpose what you're doing in your personal spaces and see where the gaps are. That's one way to troubleshoot. So I do believe that we need to be doing that. The resources are great. They're all within this room. And I'll open it up to the panel to talk to you a little bit about those resources way past and way before just the pregnancy stage. What are your thoughts here?
So I'll just comment really quickly, and I haven't shared this with you. So I just started a new role, and it's with a payer. So I'm the medical director for maternal infant health for one of the Blue Cross plans. I have several states, and thank you. So within this role, I'm now in a position where I'm looking at what resources do communities need, right? What resources can the plan have that help fill these gaps? One thing we're looking at is nutrition related to chronic disease, nutrition related to maternal health, nutrition related to pediatric. And you're so correct. When you talk about maternal health, the preconception period is important, and what happens and how you enter pregnancy is important. And so the thing I would say to you, looking at, there are a lot of companies. We have accelerators, I'm working with innovation centers, I'm doing a lot, right? But I still get concerned. I think embedding health equity frameworks can be difficult for some of the companies. They think they have it and they don't. But you got to go deep. I would just encourage you, go deep, right? Really find the worst off of the community and then work from there, because many people, what I'm not trying to do is drive my community and my people to resources and solutions that provide fragmented care models, right? One of my big concerns, any company that comes before me, fragmented care models. I'm not looking to create a new problem, right? But really thinking holistically around it, thinking about really who you meet. And I understand from a market capacity, you got to get to the numbers. But, you know, I just ask you to go deep in your models because it's important. And I'm happy to talk with you offline.
We've got another question here. That's all right.
So we're going to have one more panelist just comment, and then we're
Very
going to
good.
go to Ronke, who I know actually has an answer to part of this question too.
First, thank you, Najwa, and Dr. Madi said, for bringing that up. It's really important. And so we understand that systemic and structural racism and the weathering on Black women's bodies is one of the biggest factors that impact a healthy pregnancy. And so when we look at zip codes and we just say, you know, why are you living in this zip code? We know that you're more likely to have a premature delivery, or we know that you're more likely to have a low birth weight baby. That tells us that systemically we have issues, as Kendra said, with housing and access to transportation. And so one of the things that I think about is how colonialism and capitalism has fragmented our communities and has taken out some of the very resources that help to strengthen family units. So traditionally, in certain communities, everything was shared. You had people who did the cooking and people who helped to support with the children. And so now we have working class families, sometimes moms who have to work 2 and 3 jobs. There's time poverty. There's multiple issues. And so people aren't able to feed and nourish themselves the way that they need to. And so you have nutritional deficiencies. If you live in a community where there's high gun violence, or there's high drug use, or you live in an abusive household, all of these things are going to impact the health and well-being of families. So some of the things that I think about is not waiting again until someone becomes pregnant, but to look at family structures as a whole from a systemic point of view, and to say, how can we make communities healthy now so that when people become pregnant, we can ensure that they're well supported. And so for us to look at our individual family units, so outside of our badges, outside of our jobs, look within our own families and say, what can we do right now to strengthen our family or to get the resources that we need so that when our nieces and our grandchildren become pregnant, we know who's going to help to lighten the load for them now. And one of the things that you said, postpartum is forever, and that is true. But postpartum actually starts in preconception. Postpartum starts in pregnancy. Because whatever I do in preconception and pregnancy is going to impact my health and well-being in the postpartum period. It can have a factor on whether or not, you know, I hemorrhage or have any other complications. So I just want to invite us to look at our lives personally, invite us to look at our families personally, and see how can we start to share some of our responsibilities so that whenever a person does become pregnant, delegating roles and supporting people with their tasks are something that's more easier to do, so that when a person does give birth, we're not sending moms home at day 3 and they're still having to cook and clean and take care of their other children.
That's absolutely
so I think
right.
That's really important.
And this is such an important topic that you brought up, Najwa, that we're going to go to the crowd and we're going to speak to 2 other leaders. So we'll start with Ronke and come to Kanika right after. Ronke?
Thank you so much. And I think you asked a really great question. For context, my name is Ronke Palati. I am a mother of 4. I'm a working mother, so I come from that experience. I'm also a community leader. We have a community house that is optimized for the well-being of mothers called Corridor House. And we are launching our stage postpartum program. We actually start training people here on April 5th. And I'll tell you why, and I'll tell you what it's about. So, Okunsola said very well, we have to find the people. We have to identify them ahead of the time. And there is a really beautiful intersection from a social determinant of health between social disconnection and between familial support. The reality is that the village is fragmented. Grandma has a job. Grandpa has a job, people are not around. So when you look at data, right? So Dr. Maddie said she's a data queen with receipts. I too traffic in data.
Oh, I learned from her. Okay.
So when you look at the countries with the least amount of maternal mortality, so bottom 3 countries, New Zealand, Norway, and when you look at New Zealand specifically, they have 3 deaths per 100,000 or so in maternal mortality. Do you know what the number 1 contribution of maternal death is? 45% of all the deaths, suicide. There is tremendous amount of overwhelm that happens because the village is gone. And so I think it goes back to that community health worker mindset. We need to train and develop, from your question, Najwa, I think that's your name. So what we are doing is we're training peer group leaders, people are comfortable with people who look like them, who are well trained, where it's non-clinical in nature. And so we're training peer group leaders to support 8 to 10 women, and we're pairing it with doulas and community care workers, people who can stay with you and help you, because baby, sometimes all you need is 2 hours. And we think about what happened recently in St. Louis, the tragic death of the mother and her 3 or 4 children, right? That is years postpartum. But when you think about the cost of it, of the social disconnection, of not having somebody you can talk to, the data is clear. Not having that community support costs us $13 billion in healthcare because we're not breastfeeding, and our people specifically that look like me are not breastfeeding enough. When you look at the cost of lack of loneliness in our society, it costs us over $400 billion in this country alone. So I think we're right. It takes a village, but we have to form it. The village is fragmented, so we can't fully expect that grandma, niece, auntie is going to be there. I think we have to create those systems that is scalable. And there are many programs, Lean In Circles. They have 300,000 women in a circle. So I think we have to create those pods and then just pair the pods with. That's my solution, but there are many. So thank you.
I love that, and thank you so much for bringing that up. And as we bring the mic to my partner in crime, I think I'm also hearing that maternal child health doesn't stand alone. They're intersecting crises at the same time, and that can be overwhelming. That's what makes it difficult for us to really address this work well. I'm really proud to bring you the first ever Behavioral Health Bureau for the city of St. Louis. When I joined in 2021, I was shocked that there wasn't one person doing the work of mental health and behavioral health. There wasn't one person doing the work of violence prevention. So it was our honorable mayor who changed that and opened the first ever Office of Violence Prevention, you heard me say, but that gave me the space to focus on the Behavioral Health Bureau that she supported. And so I wanna just let Dr. Julie Gary, who's the Bureau Chief, just stand. Please make sure you connect with her today. We are doing a phenomenal amount of work. We've already put back over $1 million in community. So Naja, one of the things that I wanted to address in that question is, if we're gonna talk about funding, we're gonna talk about policy, it has to come from your health department. And so we really asked leaders, what do you need, right? And they said, you guys put out calls for RFPs all the time, but we don't even have capacity or knowledge base to apply. I didn't even have a grants manager when I started this job. That's crazy, right? So we're also pairing that with assistance to apply and assistance to keep up with the reports to keep the money. It's those types of innovation for leaders like you and Ronke and all of these other people who are doing this work to address family and to address the cascade of care, just not around pregnancy, is key too. Kanika, this is your life's work. What do you think?
Yeah, I just wanted to highlight a few things here. Real quick, what you talked about the budget. So just last year, St. Louis County Health Department, my budget was cut by $10 million. And for each dollar that's lost with a health department, we're talking about individual lives, inability to care for chronic disease, mental health. And it's unfortunate that a body of political minded people who don't understand public health decided to cut the budget by $10 million in St. Louis County. And St. Louis County is a huge health department. So now we're struggling, trying to make sure I can still provide the services to meet the needs for the community, all because of a decision. So I do want to highlight the importance of a public health budget and what we do as public health departments to truly care for the health and well-being of our communities, all the way down to the individual person. So that was so key that you said that. And we need more support and advocacy, both of us, when it comes to our budget, because unfortunately in the county, I can present a budget, but others have the final say so over how much money I get. So I do want to put that out there. Support us. The thing that I also wanted to highlight, and this was something that I was doing a lot before coming into this role, is really talking about the intersection of substance use and pregnant women. There's a huge stigma and bias there. We're already talking about a different subset of women who enter the healthcare system being traumatized. There's this fear that if I tell someone that I am on drugs, what's going to happen? And I will never forget, my medical assistant came up to me in my office about 2 or 3 years ago, and she's like, I think it's unfair. And I was like, what are you talking about? And she said, for my mom, why is it that my brother got taken away, but these women get to keep their babies? So it was a teacher moment for me to educate her on the historical nature of bias, racism, and what has happened to our Black women when it comes to substance use. But that is something while we're having these discussions, while we're talking about mental health, we have to also acknowledge that we do have women, marijuana, fentanyl, meth, all of that. But we need to create environments where women still feel supported and say, you know what, yes, I am using X, Y, and Z, and I want this support instead of, oh my goodness, you pain seeking. You want to get oxycodone for X, Y, and Z. No, I'm truly in pain. Listen to me when I say I'm in pain. So I just wanted to highlight, we're doing a lot of great things, but that is one area that I think we need to penetrate more is our women, especially our pregnant women, when it comes to substance use in St. Louis, but also in the country and the region.
Period. Whew. All right, I like to get people out on time, and we're doing well, so I can probably take 2 comments. Suzanne in the back, do you want to talk a little bit about this crisis on syphilis and congenital syphilis, and very briefly just talk to us about the solutions that you're helping to lead along with our county partners and our state partners?
Thank you. And I am incredibly grateful to the county because we go through together all of the cases.
Girl, first of all, can you tell the people who you are? This is the bureau chief for communicable diseases at the Department of Health at the City of St. Louis, who just got promoted because her innovation is so key. So can we just start there and give you your flowers? But carry on, girl.
She does this to me. Now I can't speak. So there's a couple things that I would like to say about how my role in my department or my bureau interacts with mental health, harm reduction, maternal and child health. And that is that we get to hear the stories, or we get to see on papers, reports, the case reviews of the women who we are losing. And I say that we are losing them because my counterparts at the county, and by the way, Dr. Kanika, you have fantastic people over there. I just want to say that. I will try to steal them as much as I can. Just saying it's fair. All's fair in no. But the vast majority of the women that who are pregnant and also suffering syphilis are unstably housed, have maybe had 2 or 3 prenatal care appointments, have been involved with the criminal legal system. I beg your pardon, I cannot say criminal justice system, who have substance use disorders. And all of those things impair the capacity to not only care for their pregnancy, but to care for themselves. And my challenge, and I've been beating my head against the wall trying to figure out how we honor community, how we convene listening sessions and say, here are the best practices that we have researched. What do you think, community partners? What do you think, doula coalitions, midwives? What do you think about these solutions? Can you partner with our nurses and clinics, Wish Clinic, WashU? Can you give my nurse cold chain custody of Bicillin so that we can go find this woman whose last known address was a couch somewhere in North City so that we can take care of her? And that's the gap that I'm facing. It is the intersection. That's why the department has been so intentional about meeting regularly, all of us together to address this issue. So if you could solve that problem for me, finding my unstably housed moms, I would be so grateful.
Thank you so much for bringing that up, Suzanne, and for your leadership. So under Dr. Cunningham's leadership, Dr. Hillary Reno, the county convened the first ever congenital review syphilis board. Kanika made it very clear that it was not to happen without the city being there. That's the kind of leader she is. So we now have a regional approach to this. If you're doing this work and you haven't been talking about syphilis, that's my second challenge to you. This is a national and local crisis. In the city, the numbers have gone up 600% for congenital syphilis since 2016. You don't even hear about those kinds of numbers. They don't even make sense. That shouldn't even be happening, right? And so this is a very clear crisis. So I ask you, when's the last time at one of your meetings you talked about what you're doing around syphilis and congenital syphilis? And if you are drawing a blank or you don't know where to start, the leaders are here. They're at your county and at your city Department of Health. If you are a leader in any space in this place and you don't know who Suzanne is, that's a problem. Be better. If you don't know who Kanika has to lead these things and you're in the county, that's a problem. Do better. When I lecture, one of my favorite things to do to stay grounded, I lecture, and the best lecture I've ever had is at 6th grade students. Maybe they showed up better than my residents and fellows and undergrads do. But I always start with, hey, can you tell me the address of the health department? So by a show of hands, if I were to put y'all on the spot, how many of you know where my office is? Where's the health department? Y'all don't. That was so excited to get something right. Look at them. Right? I hope to God you know where my office is. But let's try that again. I just want the room to see. And it's not to shame y'all, it's to make a point. So how many people would know where the City of St. Louis Department of Health is? Okay, that's a problem. Y'all the leaders. How many of you have visited our website in the last year? Hands up high. That's better. I'm doing better. Yes, thank you. Right? And we know it's hard and it's hard to navigate, but that's another thing Mayor Jones has taken on. She has brought us out of the ghetto of the medieval times, honey. Okay? Because everything was paper when I came to the city, and now she has taken us to platforms for innovation and technology. But if you don't know who we are and where we are, you don't know how to get those answers. And we are connected to your state partners and can do a lot of this work for you. So again, congenital syphilis is one of the biggest issues of our time. I've got time for maybe one last one before we wrap up. I see Jilliam in the back, and I'd like April as well to get the mic and just talk a little bit about, and the reason why it's important to hear from April is that I've learned more about policy in this space and health equity in this space from her. That's her life's work and passion, and she's done it in many spaces throughout the region. So we'll close with new board chair, April's jolly, but Jilliam, who also works at the health department and also just got promoted. Hey, girl! What are your thoughts here?
All right. Hi, everyone. My name is Jillian Root. I did just get promoted to public health educator at the city. I'm a small fish in a big pond, but got a big voice. And so, did it die on? Oh, okay, hold on. Here we go. All right. So one of the issues that I face, and I asked this question at a conference a couple weeks ago, and I wasn't able to get an answer. And so, you know, I don't want to put the weight of this problem on our community members and our community partners without making sure our providers know their role in this. And so how can we approach providers about their own bias and talk to them about what they're doing wrong? If we know providers, especially if you're in a role of such high esteem, you can have some type of complex of, well, I don't do any wrong, right? And so how can we come as respectfully and assertively as possible to make sure that they understand their role in this as well, instead of just flipping the script and being like, all right, we're just going to put it on midwives, doulas, and community partners, and, the providers and feel off scot-free.
Oof. Panelists,
I'll
I
take
see
that.
Dr. Cabela immediately took the mic. Can you talk to us a little bit about that?
Sure. You know, I mean, that's you know, when I think about
Oh, sorry, Dr. Cabela, can you exchange mics with Dr. Lawson? This is so important. I just want to make sure you're heard.
okay, is this better? When I think about race concordant care, I mean, I'm talking to you not only as a physician, but as a patient. I think about our pathways to becoming any type of healthcare provider, whether you're a physician, nurse, midwife, medical assistant, ultrasonographer. The pathway is, it's not a leaky pathway or leaky pipeline. We just don't have the people. It will take us, you know, over 100 years to get race concordancy. So in the meantime, we're not going to stop working on it, but in the meantime, we have colleagues, we have allies, we have people within the health profession we can continuously train. One of the benefits of being at WashU right now and our partners at BJH and BJC is there's a commitment to maternal and infant health, there's a commitment to community engagement, and there's a commitment to ongoing training. So we have training within our departments, amongst providers, about some very specific anti-racism training, trauma-informed care training, diversity, equity, inclusion training, and you know, I created an office at WashU. Darius, I think he's here. Dr. Darius Whitaker is the program coordinator for our IDEAS office and community engagement. What I tell people is, what does IDEAS stand for? It's IDEAS squared, inclusion and innovation, diversity and discovery, equity and excellence, because you can't have excellence without equity, advancement, and advocacy. So we are doing this work in these institutions at the local level, and we also need to engage communities to show that we're doing work, and we need to show up with it. So I applaud your question. I agree with it wholeheartedly. We have a long way to go, but we are doing the work.
Thank you. Kendra, you look like you also have something to add.
Yes, I think training is critical and foundational, and we need accountability in our systems for ensuring that the care is delivered according to the standards and the quality and the excellence. Individuals need to be held accountable in the institutions in which they work. And I believe that that also needs to be accountability to the community. And there's a lack of information at the community about what our institutions are doing to ensure respectful care, to ensure quality care for Black women. It's not well known, and I know there's a lot happening. There's a lot of people committed and engaged in this, but it's not well known. And so I think we need more interaction. We need people at the table together, providers and community members who are talking about this and giving feedback on an ongoing, continuous basis to our providers about what we're seeing and feeling and experiencing and how it's going and where there's opportunities for more. And I think that we've seen a greater acceptance and interest in listening to community, but only really to come out to community to listen, where we've convened in spaces like that are facilitated and hosted by conveners. Less so individual institutions creating that internally in ways that they have their own internal accountability structures to community directly. And so I'd really encourage and challenge our institutions to do that more. And not to say we need marketing campaigns to show everything that is happening in institutions, but we just really don't know what is happening in the training in the Washington University. That's really innovative things that you're doing to train providers that we've never seen before, but we don't. The community just doesn't know. So how do we get more active connection to be part of that?
Thank you so much. And we're over time. So April, you've heard a lot today, and it's one of your talents is active listening. You've taught me a lot about policy as well. What are some of your thoughts to close us out?
First of all, my name is April Jolly. My thoughts are after hearing all the things that you all have said. I've heard a lot about integration, accountability, and vision. So my question is, what does that look like? Particularly folks who are in institutions and systems who have a relative amount of power. How are you wielding or yielding that power to impact internal policy and practice? Because it's both grassroots and grass tops. We need everyone at every level of every system, right, to start to make change. And I would just advocate for people looking internally. What is the state of your workforce? The community. We are people who work in places. How are you treating the people that are working in your spaces? If you can address that, you can have a little more credibility with how you then present to policymakers about what the actual change is going to look like. So I would just encourage people to be looking both internally as well as externally. We love to point fingers, and we should, especially in Jefferson City. However, we also need to look internally, because if your vision is that everyone have a equitable and thriving life, what does that look like in spaces you currently occupy? And so let's think about vision both in the broad sense and also in the practical sense. That's what I am hearing.
Oof, come on. Listen, We went over today, but I'm not sorry, y'all. I'm not sorry at all. My heart is very full. Shantae will tell you that I was nervous and I was a little bit of a bridezilla about today. Because I've never put together an event with my name on it, and transparently and vulnerably, I didn't think anybody would show up. And so, what is beautiful about today is that people showed up not because my name was on it, but because you all care so deeply. Because even though you all lead this work, it was still important to you to show up and listen. It's the humility of CEOs, Risa, showing up, and you didn't say a word. I'm almost mad about it, right? But you are one of the most active listeners, and so many of the other leaders in this room are like that. Y'all stayed, y'all were engaged. So if you are worried about this crisis, don't be. Just look around and feel and remember what today felt like, right? Because we're going to go back to our offices, and you're going to go back and you'll have accumulated about 100 emails, and a lot of things are going to happen. But I want you to just stay a little bit more present as you're milling around and meeting people and giving them your business card. I want you to stay a little bit more present and just allow yourself to feel the hope and to see that you have people who have your back. They may never email you for the next year, but they have your back because they're doing this work alongside you in community. So I want to thank you. I want Shantae Fluellen just to come to the front of the room because she did all of this. My love for this woman is not a secret, and I don't care that everybody knows. Shantae Fluellen is the manager for community outreach and communications. This is actually her onboarding period. She is in training right now, and she did this. She is phenomenal. She is excellent. And I really would love for you to take some time to meet her because she is bringing together the first ever strategic plan for community outreach. Through the support of our mayor's office, we have ARPA dollars and community vans. We are innovating and bringing public health to your doorsteps and to your community in the realest sense. We have mobile outreach community vans. They have our brand and our logo, Lakeisha. And they can come to your communities. We'd love to partner with you. Our legal office has made MOUs very simple so that you can have them once a week or once every 2 weeks, and she's putting together that plan. But I just want to thank you for how you show up in your love language is this. And you did it calmly, beautifully, gracefully. And I just honor you and your leadership today. Thank you, Shantae. But stuff like this doesn't happen if somebody doesn't pay the bills. Dr. Lawson, Derek, we honor you. You fly across the country and show up for Black leaders. You make it a priority. This man right here reached out and he said, "What can I do to support you?" And then he said, "Just send us the bill." That's crazy. When does that happen? Right? But it happened to us. So I just want to say thank you. Jesse, I kept it together for most of it, right? Like, I did okay today. Come on, man. So I want to thank you, Dr. Lawson, so much for sponsoring this event, for showing up for us, for flying here. You're flying out shortly after this. We honor you. Thank you to all of you. Through collaborations, partnerships, and hard work, the next time we meet on this topic, we'll see the difference. We'll feel it. We got this. I wish you well as you head back out into the community. Enjoy each other, and thank you so much.